Hello, we are Halmer Castaneda and Emilio Rodriguez, and today we're going to present to you mood disorders.
Mood disorders are characterized by severe disturbances in the mood and emotions, most often depression, but also mania and excitement. All of us experience fluctuations in our moods and emotional states, and often these fluctuations are caused by events in our lives. We become excited if our favorite teams win the World Series, and sad if our romantic relationship ends or if we lose our job. At times, we feel fantastic or miserable for no clear reason. People with mood disorders also experience fluctuations, but their fluctuations are extreme, distort their outlook on life, and impair their ability to function. The DSM 5 lists two general categories of mood disorders: depressive and bipolar disorders. Depressive disorders are a group of disorders in which depression is the main feature. Depression is a vague term that in everyday language refers to an intense and persistent sadness. Depressed people feel sad, discouraged, and hopeless. These individuals lose interest in activities once enjoyed, often experience a decrease in drives such as hunger and sex, and frequently doubt personal worth. Depressive disorders vary by degree, but this module highlights the most well known: major depressive disorder, sometimes called unipolar depression. Bipolar and related disorders are a group of disorders in which mania is the defining feature. Mania is a state of extreme elation and agitation. When people experience mania, they may become extremely talkative, behave recklessly, or attempt to take many tasks simultaneously. The most recognized of these disorders is the bipolar disorder.
Let's start with major depression. According to the DSM 5, the defining symptoms of major depressive disorder include depressed moods most of the day, nearly every day. So, feeling sad, empty, hopeless, or appearing tearful to others. And a loss of interest and pleasure in usual activities. In addition to feeling overwhelmingly sad most of the day, people with depression will no longer show interest or enjoyment in activities they previously found gratifying, such as hobbies, sports, sex, social events, time spent with family, and so on. Friends and family members may notice that the person has completely abandoned previously enjoyed hobbies. For example, an avid tennis player who develops major depressive disorder no longer plays tennis. Now let's move on to the diagnosis. To receive a diagnosis of major depressive disorder, one must experience a total of 5 symptoms for at least a 2-week period. These symptoms must cause significant distress or impair normal functioning, and they must not be caused by substances or a medical condition. The symptoms may include fatigue or loss of energy, feelings of worthlessness or guilt, difficult concentrating and indecisiveness, suicidal ideation, which might be thoughts of death, thinking about or planning suicide, or making an actual suicide attempt. Other symptoms might be significant weight loss or weight gain, and or significant decrease or increase in appetite, having difficulty falling asleep or sleeping too much, psychomotor agitation, which is when the person is noticeably fidgety and jittery, demonstrated by behaviors like the inability to sit, pacing, handwriting, pulling or rubbing of the skin, clothing, and other objects. Or psychomotor retardation, which is when the person talks and moves slowly, for example, talking softly, very little, or in a monotone way.
Risk factors for major depressive disorder. Major depressive disorder is often referred to as the common cold of psychiatric disorders. Around 6.6% of the US population experiences major depressive disorder each year. 16.9% will experience the disorder during their lifetime. It is more common among women than among men, affecting approximately 20% of women and 13% of men at some point in their life. The greater risk among women is not accounted for by a tendency to report symptoms or to seek help more readily, suggesting that gender difference in the rates of major depressive disorder may reflect biological and gender related environmental experiences. Lifetime rates of a major depressive disorder tend to be highest in North and South America, Europe, and Australia. They are considerably lower in Asian countries. The rates of major depressive disorder are higher among younger age cohorts than among older cohorts, perhaps because people in a younger age cohorts are more willing to admit depression. Several risk factors are associated with major depressive disorder. Unemployment, including homemakers, earning less than 20,000 per year, living in urban areas, or being separated, divorced, or widowed. Comorbid disorders include anxiety disorders and substance abuse disorders.
Bipolar disorder. A person with bipolar disorder, commonly known as manic depression, often experiences mood states that vacillate between depression and mania. That is, the person's mood is said to alternate from one emotional extreme to the other. Now let's move on to the diagnosis. To be diagnosed with bipolar disorder, a person must have experienced a manic episode at least once in their life. Although major depressive episodes are common in bipolar disorder, they are not required for a diagnosis. According to the DSM-5, a manic episode is characterized as a distinct period of abnormally and persistently elevated, expansive, or irritable mood and abnormally and persistently increased activity or energy lasting at least 1 week. During a manic episode, some experience a mood that is almost euphoric and become excessively talkative, sometimes spontaneously starting conversations with strangers. Others become excessively irritable and complain or make hostile comments. The person may talk loudly and rapidly, exhibiting a flight of ideas or abruptly switching from one topic to another. These individuals are easily distracted, which can make a conversation very difficult. They may exhibit grandiosity, in which they experience inflated but unjustified self esteem and self confidence. For example, they might quit a job in order to make it big in the stock market, despite lacking the knowledge, experience, and capital for such an endeavor. They may take on several tasks at the same time, and yet show little, if any, need for sleep. Some might even go for days without sleep. Patients may also recklessly engage in pleasurable activities that could have harmful consequences, including spending sprees, reckless driving, making foolish investments, excessive gambling, or engaging in sexual encounters with strangers.
Risk factors for bipolar disorder. Bipolar disorder is considerably less frequent than major depressive disorder. In the United States, one out of every 167 people meets the criteria for bipolar disorder each year, and 1 out of 100 meet the criteria within their lifetime. The rates are higher in men than in women, and about half of those with this disorder report onset before the age of 25. Around 90% of those with bipolar disorder have another disorder, most often an anxiety disorder or a substance abuse problem. Unfortunately, close to half of the people suffering from bipolar disorder do not receive treatment. Suicide rates are extremely high amongst those with bipolar disorder. Around 36% of individuals with disorder attempt suicide at least once in their lifetime, and between 15% to 19% of complete suicide.
Now let's move on to the biological basis of mood disorders. Mood disorders have been shown to have a strong genetic and biological basis. Relatives of those with major depressive disorder have double the risks of developing major depressive disorder, whereas relatives of patients with bipolar disorder have over 9 times the risks. The rate of concordance for major depressive disorder is higher among identical twins than fraternal twins, 50% versus 38% respectively. And the same happens with bipolar disorder, 67% versus 16% respectively, suggesting that genetic factors play a stronger role in bipolar disorder than in major depressive disorder. People with mood disorders often have imbalances in certain neurotransmitters, particularly norepinephrine and serotonin. These neurotransmitters are important regulators of the bodily functions that are disrupted in mood disorders, including appetite, sex drive, sleep, arousal, and mood. Medications that are used to treat major depressive disorders, such as selective serotonin reuptake inhibitors or SSRIs, typically boost serotonin and norepinephrine, whereas lithium, used in treatment of bipolar disorder, blocks norepinephrine activity at the synapses. Since the 1950s, researchers have noted that depressed individuals have abnormal levels of cortisol, a stress hormone released into the blood by the neuroendocrine system during times of stress. When cortisol is released, the body initiates a flight or fight response in reaction to a threat or danger. Many people with depression show elevated cortisol levels, especially those reporting a history of early life trauma such as the loss of a parent or abuse during childhood. Such findings raise the question of whether high cortisol levels are a cause or a consequence of depression. High levels of cortisol are a risk factor for future depression, and cortisol activates activity in the amygdala, while deactivating activity in the prefrontal cortex. Both of these disturbances are connected to depression. Thus, high cortisol levels may have a causal effect on depression, as well as on its brain function abnormalities. Also, because stress results in increased cortisol levels, it is equally reasonable to assume that stress may participate in depression. Thanks for your attention, and we hope you enjoyed. Now let's move on to the biological basis of mood disorders.